All right, as I mentioned, thank you for everyone's patience as we are about to get started. We would like to start by welcoming everyone to Wednesday Wellness, which is a free live educational series by Trinity Health. And we're thrilled that you have joined us as we dive into this important topic of heart health essentials. Before we get started, we would like to just provide you with a few housekeeping notes. Participants' cameras and microphones have been turned off to ensure a smooth experience. If you have questions during the presentation, there is a Q&A chat feature that's located near the bottom of your screen. Presenters can address additional questions that may come up near the end of the presentation. Lastly, today's webinar is being recorded, and we will provide all registries with a link to that video in the next couple of days via email. And without further ado, it is my pleasure to introduce you to our presenters today. We have Dr. Alexander Ganem, a primary care physician, Dr. Angela Ganem, a cardiologist, Dr. George Ganem, a cardiologist, all with Trinity Health Medical Group. Thank you guys for being here.
Thank you.
Yeah, thanks for having us. It looks like George and I became MDs, so that's cool. So we're kind of doing this in more of a discussion format. And I think the way this is going to go is I'm going to kind of get the questions out there, and I'll let me, George, and Al have at it and see who gets the win on answering. So let's go to the next slide if it will let me. Okay, so here's the first question.
Oh, man. Well, it's the leading cause of death in the United States. We can start there. So trying to get your heart as healthy as possible is very important. There's a lot of risk factors that come into play. A lot of things that we do on a daily basis that affect this. Man, it's just so important. George, Ange, you want to add to that?
Well, I mean, the heart is in the center of the body for a reason because it's the core of everything. And I'm sure that any neurologists or neurosurgeons on here will disagree about the core, but if the pump's not working, everything else cannot get fed. So there's a reason why God only gave one of them compared to kidneys. Throwing some shots at some nephrologists out there too.
Yeah, I think heart health, just as Alex kind of said, it's kind of one of the leading causes of death still. And I think even when people come into the hospital, there is a lot of complications that unfortunately can be found even with your heart at that time. So I do think that kind of determining and getting this stuff done even before you meet, unfortunately, either George or I, usually in the hospital, is really important, which is where I think Al comes in. So
also, just to be like the piggyback on that too, the traditional thought process of heart health is that, chest pressure, tightness, which is actually one of the minimal as far as presentation with actual problems that patients come in with. So heart is very important, and we're learning, especially as we have progressed in time, that it presents very differently in women compared to men as well.
Yes. And so kind of moving on for these, we're going to talk now, what is the most common heart-related conditions and what trends are you seeing in your daily practice?
Oh, man, heart-related condition. Well, a lot of the main ones. So diabetes comes to mind right away. I treat a lot of patients with diabetes. Any patient that is starting to develop diabetes or elevated blood sugar or metabolic syndrome, which is kind of a precursor to all of these, your heart is at risk. You're doing damage. I like to tell my patients that when you have elevated blood sugar, you have to realize that the sugar is there in your blood. It's damaging your vascular system because it's on a very particular balance it likes. So when you have that extra sugar in there, it damages the vessels. So vessels and the heart, they go hand in hand. It's one of the big things I try to focus on. George, Ange?
How about cholesterol?
Cholesterol is huge as well.
Absolutely. Hyperlipidemia, high cholesterol, high blood pressure, hypertension, and diabetes are the big leading causes of heart-related conditions. And traditionally, in any of those situations, you're talking about vascular complications such as myocardial infarction, heart attacks. We're talking about hypertensive heart disease, which is thickening of the heart because it's just like any muscle that you're using. If you have high blood pressure, like if you grab weights and you start lifting 10-pound weights and you drop that down to 50-pound weights, your biceps going to grow. The heart is going to grow against higher pressures and higher stress on it. The difference is the heart has no room to grow. So it grows both outward and inwards. So like I said earlier, the heart is just a pump. Its sole reason is to take blood and give it to the rest of the body. And if you have a smaller cavity, the heart has to work faster and harder to pump the same amount of blood.
Yep.
What do you guys? Go
As
ahead,
that
sorry.
muscle grows, it's just that this chamber gets smaller and you have less room to squeeze blood.
What are the trends are you seeing? So like, I think what this question is trying to get at is like, what are you seeing? Who is presenting with like these risk factors for heart disease? Like, how old are these patients? Does it matter? Like, how many patients are you seeing in your clinic and you're like, oh my gosh?
I'm definitely seeing more and more younger patients that are presenting with the metabolic syndrome with hyperlipidemia, meaning high cholesterol, high triglycerides. A lot of people don't realize that they have high triglycerides that run in their family. So they're not often getting these checked. They're ignoring family history, or they just don't know. A lot of people don't communicate with their parents about what kind of diseases and things are going on. So being open with your family and kind of discussing that is very important. That way, when you're coming in to see any of us, we have a better idea of how to strategize and what your risk factors are.
And how about you, George?
Everybody is coming in more. We're seeing much younger individuals. I mean, we here, especially in America, we're having an obesity epidemic. So that's causing heart disease to occur much younger. And we're seeing a younger generation, and the hospital systems in general, all of them are gearing up to be seeing both the baby boomers aging population. So we're going to get an influx of patients from that standpoint, and also younger patients. And to be honest with you, a lot more women are now seeking heart health, where traditionally they did not, because it was always seen as more of a male-oriented kind of disease, which it never was. It's always been in both genders. So it's something, though, that women are taking the initiative and coming to be seen directly for their heart health. Minorities are also being seen more often. They traditionally have not been coming in for treatment just because of socioeconomic pressures, and we are seeing a lot more step in and be treated.
And I think kind of to piggyback both of you, I think as a female cardiologist, sometimes have a very unique perspective, as I think a lot of women luckily feel comfortable to talk to me. And I think some of the things we don't talk about that are really common for women to have in relationship is as you go through pregnancy, having a premature baby, having preeclampsia, having gestational diabetes, having like hypertension, having some of these having PCOS, having underlying autoimmune diseases. All of these are risk factors for the heart-related conditions like diabetes, like hyperlipidemia or high cholesterol, like, as Al said, something called metabolic syndrome. Just to piggyback on that, because I think a lot of people, this is a term that I think grew out of favor. And then now with the creation of the GLP medications, I think metabolic syndrome has kind of come back more for a lot of us to use. I know I'm kind of off topic on the slide. I'm just going to follow where it goes. What is metabolic syndrome? How do you explain this to your patients? Like when they come to talk to you, what do you tell them about
it? I like to start off with just telling them, starting with the topic of diabetes and not diabetes, obesity, because metabolic syndrome, some of the way that we really diagnose this is we look at certain markers. So we look at your waist circumference, we look at your blood pressure, we look at traces for high cholesterol. And if you're meeting certain of these criteria, then you're putting yourself in what we call this metabolic syndrome. And what metabolic syndrome really may be pointing to is more a precursor for insulin resistance, which is how diabetes really develops.
Absolutely. The just pushing that further, the idea behind diabetes is it's always been seen as a disease of excess. Initially, it is, but it's not. It's actually your body is starving because what happens is you have so much sugar that's in the blood that the cells actually block the sugar from coming in. And the way sugar comes into the cell is through insulin. So the body says no more insulin. So that's why traditionally, when you're treating diabetes, you're giving people insulin so you can drive the sugar into the cell. But that's basically what you're causing is that the cells are starving. So because the cells are starving, it causes a whole cascade of problems, a whole cascade of damage in every situation. Vascular and particularly the heart sees it so much is if you think about it just in general terms, the body is going to break down, which is utilized the most. So the heart never stops. So since the heart never stops, you're going to see breakage in the heart sooner than in other organ systems because it actually physically has to move consistently. Same reason why people will say that there's problems with digestion and gut or skin. Anywhere where the cells that are being used more often are going to have the most effect.
Okay.
Yes.
Yeah, I think I agree on both points. I think for this one, I'm going to move on to the next question just so we can kind of get a bigger idea because I think the big thing is to talk about all of us related together. Let's see, heart disease risk factors are often, oh my gosh, silent. What are the top risk factors that you most often see? And which factors are most often overlooked by patients? I think we kind of touched on this last time, talking about metabolic syndrome, talking about high cholesterol. I think the one
Family
that I
history.
as cardio, which would you say, Al?
I said family history.
Family history. And specifically, I think when Al's talking about family history, the way we learn it is if you're premature, meaning that if you have a heart attack or a stroke or something if you're a woman before the age of 65, and for a men before the age of 55. But I would say even some of the other things, and I think George and I wish, and I think Al too, like when we talk about hyperlipidemia, I don't think we're overlooked. I think they kind of don't realize that when we're trying to get them on medications, specifically, I think statin is the most controversial and the one that I think actually helps the most. It's not overlooked. We don't think it's that serious or that helpful. And I think that's kind of where I'd like to start this question as more of the risk factor of hyperlipidemia. Why do you think a lot of people don't really compute it that well? And why do you think some of the treatment have been kind of not seen as essential by patients?
You don't see an immediate benefit, a lot of times people with hyperlipidemia or high cholesterol, you don't have any signs or symptoms for it. You can feel completely normal. In fact, a lot of my patients say, Doc, I'm feeling fine. Why the heck are you trying to stick me on a medication? And I'm telling them that we are looking at your overall risk factors, and we have special calculations that we use, and we basically come up with a percentage of what are the chances of you having a heart attack or stroke in the next 10 years? Okay. And anything above 5%, we have to start talking to you guys and saying, hey, lifestyle changes, medications, things like that. And then we start getting above 20%, we're really, really, really pushing these medications because we're basically saying that, there is a good chance you're going to have a heart attack or stroke in the next 10 years. So it's hard for patients to see that because they're feeling fine. But trying to educate them more and just saying, like, we're looking towards the future, think about family, as a lot of my older patients, they have grandchildren, and you want to be there for your grandchildren as they're growing up, as they're going through school. You want to be there for their events. You don't want to have complications from a heart attack or, God forbid, pass away from it. So, trying to keep you around and healthy as long as we can is important when it comes to these medications, specifically the statins.
I think the big hesitance that a lot of patients have and why they're overlooking it too is the idea is that, we're taking a drug and a drug is not something that's naturally occurring in your body. And, we have this idea of such a beautiful machine, that was created that, it can heal itself. it's a beautiful machine and it can fix a lot of things, but we also have to remember it will break down. And, sadly, no one has discovered, the fountain of youth, the ability to push this back. So we eventually will all pass away from this. And when we're talking about particularly in mine and Angela's setting, when we're seeing someone, they have cardiovascular disease, where they have blockages in the arteries, is that it's no longer a preventative situation. You now have a disease. It's no longer, let's take the car in so it doesn't break down. It has broken down. So now that it's broken down, it has to come in and be tuned up more often. It has to be taken, oil changes more frequently, all these situations, because we've reached past the point of, hey, can we stop this? It's begun. The disease process has happened. Now we have to try to mitigate its advancement. So, and when we look at it and you say, okay, well, it's even if they say, well, doc, it's in one vessel, there's nothing else. You're seeing it in one vessel. But remember, if you put end to end all your vessels, you can go to the moon and back. And that's how far of distance you have in vessels within each human's body. So you may see it in one thing, but the disease process is occurring to all situations. Like, I tell all my patients, like, when they come in for even a CVA, like, a stroke, a highway is a highway is a highway is a highway. You know what I mean? Whether it's an 18-lane highway or a little bitty off-ramp, they all are roads, and they're all in Michigan, and they're all getting blizzards. So, and they're all getting the hot weather too. So you're having the problems in the same situation.
Okay. Yeah. I think I agree with kind of everyone here on this one. I don't think I have much to add on that. And I think the only one thing that I would keep in mind when it comes to statin therapy, I know this wasn't a direct question, but that medication provides a benefit besides cholesterol, which I think that it's very hard for us doctors to sometimes try to explain. But when you have chronic damage, you have all things are trying to build. And what this medication does is, let's say you have a plaque that's built and inside of it is like dead tissue. This makes it so that we create and change this dead tissue into something like calcium, which people see as bad, but in arteries, calcium is not going to move. And so in some ways, that's actually of a benefit when you're using this medication. Unfortunately, it does have some side effects and people do feel it. But if you're not having the side effect and you're tolerating it well, the cardiologists and like primary care doctors, I think all of us are going to push it a little bit more just because we know that there's another benefit that it's really hard to explain.
Yeah. And when it comes to side effects, I try to educate patients as much as we can about what are the side effects and so on and so forth, but also to keep in mind that side effects are not a guarantee. Okay. Side effects are what can happen while taking a medication, and every person is different. We have to monitor them closely, which is why I try to bring my patients back when we start them on medications and educate them to decide, hey, are you actually having side effects from the medication, or is this something else going on? So just keep that in mind as well.
I think some of the things as we're going through to kind of like talk about that is to highlight is one of the things that we wanted to talk about is like how cardiology and primary care here really communicate. And I think the statin discussion and having educational seminars and like Al either picking up a phone or messaging me and being like, yo, what's going on? Or messaging George and being like, hey, what's happening? This is going on. How aggressive would you be? My patient's worried about this. How do we do this? I think is one of the big key things. And this question coming up here, which is like, how do heart health systems between men and women, and why is the difference important for both providers and patients to understand, is one of the key highlights, because most of the time you really won't be seeing George and I first when it comes to symptoms. We are really not the first line doctors. You're usually meeting us when something has gone terribly wrong. And so you end up seeing Al first, and Al has to know all these things beforehand and how to communicate with us to like tell us what's going on. So Al, like, I guess I'm going to have you start with this one. How do they differ, and what are you asking patients about this?
It's picking up, especially when it comes to the difference between men and women. Men, it's usually pretty obvious for the most part. If I see a guy who has been hardworking for the last 65 years, they tend to ignore symptoms. And I realize that, if they're having shortness of breath, nah, not having shortness. No chest pain here, doc. But, when I'm mowing the lawn, I just can't go as far as I used to. Things like that really stick out to me. And I'm starting to say, okay, something might be going on in there. Whereas it comes to my female patients, they tend to think that their symptoms are because of something else. Okay. Um, they don't see the heart as a main issue for them for some reason. And some of the symptoms that they can have when they have cardiovascular disease is shortness of breath, on exertion, or with increased anxiety. Anytime the heart is working harder, and remember, when you're under stress, your heart is working harder as well, and you can feel changes. And sometimes a lot of people think, oh, it's just my stress, it's just my anxiety acting up. In a lot of cases, it is, but we need to do our due diligence and make sure that it's not the heart, because it can always be. And those can be very minor symptoms, such as fatigue and shortness of breath, that I've seen in the past that female patients are coming in with. And we end up doing stress tests where we stick your butt on a treadmill and look at your heart, and we seeing stuff is going on. And then I get you over to George or Hange. But that's usually what I'm seeing with the differences. But Ange, maybe you can speak more to this too.
Yeah, I would say that for when it comes to women, I will say this. I think the heart health symptoms for men and women, I think coming as a female cardiologist and having a high female practice, I think I have a unique perspective because I do think that men also actually have these symptoms. I just think we are willing to believe them more and have a lower index of suspicion that something is happening than we do with females. And I think that's luckily changing with time. But when I have people who are coming in for like women, I'm hearing it. They're talking about anxiety. They're talking about shortness of breath. They're talking about fatigue. They're talking about, I'm napping more. I'm like, okay, well, that's weird. Did you ever nap before? They're talking about, well, I'm trying to chase my grandkid around and I'm noticing that I can't do A, B, and C. They're talking about, yeah, I have this feeling that sometimes I'm feeling lightheaded, but when I'm trying to do activity, like all of a sudden, like I'm pushing myself on the bike or something like that, or I'm walking around in the grocery store and I'm just having to stop. And I think both of these things happen to men and women. I think the unfortunate way that the healthcare system worked beforehand is that for some reason we just thought women were super women, which we are, but I like we do have heart symptoms, and unfortunately, as I think George, Al, and I both know, like when women also go into menopause, like we race to catch up with the guys. We just want to beat them at everything. So we start having issues with our heart way more than the guys do at that point. And I think part of that is because we're not tested at the time we should be. I think the big thing to also understand about some of the stuff that happens with the heart, and when I'm having a story and I'm listening a story, I'm always asking, what are you doing at the time symptoms started? If you're sitting and you're watching TV and you watch something that's like fine or whatever, I'm a little worried, but not as worried, and it goes away in a few seconds. If you're telling me, man, you know what? I was outside, I was walking for a little bit, and I just had to stop, and it felt like an elephant was sitting on me. That's scary. That to me, anytime with either activity or like, God forbid, you're in a situation and you're arguing with someone or you're hearing something scary and you start to have that chest pressure. Those are things to me that I'm like, okay, something's probably going on at this point, and we really need to take a look.
Yeah, I specifically am always asking, with the chest pain or the shortness of breath, are you getting better when you're slowing down? Like when you have now, whatever you were doing, you're taking a seat and you're like, okay, I just need to catch my breath. And then all of a sudden the pressure is being relieved, your shortness of breath is coming back. Then, is going away. Then I am much more likely to say, hey, we really need to check out the heart here.
Yeah. How about you, George?
I agree. And I think the big thing that traditionally, with women in particular, why it's been such a struggle is really the PR. Traditionally, the PR for looking for women's health has been with breast cancer, as it should be for the longest time. But coronary disease took more of a back seat. And this has to do with hormonal changes, hormonal imbalances, and also cardioprotective situations that estradiol, which is produced by the ovaries when women are menstruating, that helps the heart. So also that's why I think as physicians in general have a tendency not to look at the female population until they have gone through menopause, because that's when the spike has happened. There's a very linear correlation with coronary artery disease over time with men, whereas with females, it happens after menopause. There's a huge spike, and it actually overtakes men with coronary disease as far as events. So it becomes even more prevalent and it becomes even worse because it's such a fast buildup compared to men, where it's very linear and over time.
Yeah, I think that kind of answers that question, unless you guys have anything else on that one.
No.
All right, Al, this is you. You got this.
Let's see. How do primary care providers typically identify early signs of heart disease or other heart health concerns? How does the early detection impact care plans? Oh man, I mean, you're talking about changing from just, oh, we might get you on some medications to, oh, no, you got to go see George or Ange and have them stick a wire in and take a look at your heart. These are two very different things depending on how early we're catching this. Okay. Early signs of heart disease. If I see people that are coming in that are, family history of heart disease, they have just a little bit of high blood pressure here and there. They're coming in with high blood pressure, then it settles down. Cholesterol is right on the edge of being high. A lot of these are early signs that we might be having an issue with the heart down the road. Blood sugar, another important thing that we're always looking at. Diabetes is a big thing right now. Most people don't realize, but it's part of normal labs that we look at. It's one of the reasons we're always asking you to fast for your labs, because we want to see what your blood sugar looks like when you're fasting, specifically in the morning. It gives us a better idea of how at risk you are for a lot of different things. And then also we have smoking. Smoking is a big one. Anybody who is smoking, you're going to have issues with your heart. If you don't, I'd be shocked. Okay. But getting you on a plan to help you quit, decrease smoking, is very, very important. So when I see these signs and symptoms, these signs that come on, that's when I start asking my probing questions, just a little bit depth, seeing how bad patients are feeling on a day-to-day basis. Fatigue is a big one, but it has a lot of different things that could be causing it, but heart is always on the forefront. Are you having these issues because your heart's having an issue? And we won't know until we start exploring. So, yeah, I would say, how do we identify the early signs? Is we communicate. I sit down and I talk with you. You have to be honest with me, and I'll be honest with you in turn. And when we have those open communication plans, I can get to the bottom of it. Or if I am stumped on something, I can reach out to my cardiology brother and sister and get a better idea of what might be going on, which has been extremely helpful for the both of you. So thank you, by the way. But that's really,
How about
really how it
education,
goes.
Al? Because you talk about communication, but how about like education about the
Oh,
signs of like a heart attack? Do you kind of like, as we're having this conversation now, I know these things can help people, but sometimes people either are not able to look that, or they're telling us
yeah,
about a chest pain and we go, oh my gosh, we're not concerned. And then they're like, okay, but I'm having chest pain. How come you're not concerned? And when should I be?
yeah. I mean, the classic chest pain is going to be, I feel like an elephant sitting on my chest. If I tell patients that all the time, if you feel that, you get your butt to the ER. Okay. Um, at any point, you need an EKG, you need to have it looked at. George and Ange will probably come check on you while you're in the hospital if they see anything. That's really the big one. Shortness of breath on exertion, depending on how severe it is. If you feel like you can't catch your breath, if your lips are turning blue, anything like that, you need to go to the hospital immediately. Otherwise, you need to come see me so we can talk about it and see how bad it is. You know, education in terms of symptomology is important, and in terms of what all of these disease processes do, and it takes time. So don't be upset with yourself if you don't remember something from a visit, you didn't understand something. Please reach out to me again, come back in. I try to talk to my patients about it multiple times in a row, because it's not easy. I mean, Ange and George went through how many years more of medical school and training for me for the heart, and I went through a bunch myself, and we could still miss things. So trying to get to the early signs is important. Fatigue, shortness of breath. Are you having issues laying down to sleep at night, feeling like you can't get your breath then? How far can you walk? Is a flight of stairs difficult for you? These are all really, really big things. So, yes, education is huge.
Awesome. Thanks, Al. George, I was going to ask you, I have this question from patients a lot because we have a lot of older patients. We have and you have also especially some pretty sick patients with something we call pulmonary hypertension, which may or may not be worth something to discuss in the future because that's high prevalence in what we know about. But one of the questions I wanted to ask, and I get a lot, is how do you tell the difference between someone who deconditioned because of age and someone who's maybe having a problem with their heart with these very vague shortness of breath and fatigue symptoms? What do you tell people?
Well, I mean, I think a good rule of thumb is a deconditioning usually has a cause. Did somebody just get a knee replacement? Were they just sick? Did you have a really bad bout of pneumonia? Did you suddenly just have it? So I mean, we live in the Midwest and the winters have been absolutely horrendous as of late. So you're going to have it. So, hey, in the summer, I was able to walk. And then now after winter, I just noticed that now that I'm walking again, I don't have the same oomph that I once did. The question is it getting better? You know what I mean? If you're having an elephant on your chest or you can't breathe and you feel like to pass out, no, don't keep walking. You know what I mean? We want to make sure you gotta put some common sense into it as well. But if you're saying, hey, I'm walking, I used to be able to walk 2 miles. Now I can only walk a mile. But after about a week, I could do a mile and an extra quarter mile, and then you can able to regain things that you initially had lost. It's a good rule of thumb that was deconditioning because your body is getting reacclimating to the extra effort that you have to put in. But if it's something that is just not getting better and it's slowly getting worse, because remember, when we're talking about the heart, you can never really fix anything with the heart, because if you break your bones, we put it in a cast, we tell you don't use it. You know what I mean? Leave it alone for a month or so. Then you take the cast off, you still have a bum leg. Everyone will tell you, well, that leg I broke, it always gives me problems. If I stop your heart, it's game over. So it'll never actually get better. And that's part of the reason why everyone's like, man, these docs just keep throwing medications and medications at us, because we have to, because we can never let the heart fully heal, because it can never fully rest. So we're always thinking about, you're thinking of a dam break-in with little holes in it everywhere. So what you're doing is you're plugging it up, and you're plugging it up with this med, and then you need this med, and then you need this med. Sadly, it just becomes that you become a walking pharmacy. And it's sad because we're just not able to have understood yet to that ability, because we're not able to actually fix the underlying cause. Because even when our body, which has such great self-regenerating qualities, it cannot fix major damage to the extent that we want it to, because we continue to age and we're continuing to do damage to it. You know what I mean? That's just a sad fact. But if it's getting better, the likelihood is it's not the heart, because you got to remember, if you're having a blockage and you're having pain when you get when you're exerting yourself with the heart needs more blood. It's saying that there's not enough blood that can go through that blockage. So that blockage doesn't go away. It just never goes away. So if it's getting better, the likelihood of that it's a blockage or something that's causing it becomes less.
And so I think thank you so much for that, George. Whoops. Um, I'm trying, guys. So my reason for kind of answering and asking that question was kind of more to say, how does this impact early detection care plans? This may even say Al goes and tells you, I need you to walk more. And it's not because he's saying, oh, I need you to do this. He's literally saying, I need you to walk more so I can see if you have symptoms. I need to see what is your body doing when we're stressing it. And so that's kind of where I was going with that question on it.
Oh yeah, that becomes very difficult because some patients, you have chronic pain from other issues going on, arthritis. A lot of people have issues with their knees and their hips. You can easily become deconditioned with that. That's why I stress, if you're having issues with it, we need physical therapy. We need to improve it. If we're not improving it, we can't see what's really going on.
All right, guys, let's go to this next question. Let's see. Oh my gosh, this little pop-up is immediately always in the way. Hypertension is one of the most common conditions managed in primary care. What is Trinity Health doing to support those with high blood pressure, and why does this matter for long-term heart health? So I think let's scoot this towards George first, so we can talk about some of the stuff that we're doing in cardiology, and then we'll come back to Al. George,
sorry. This is a major focus. High blood pressure is extremely important. When we're talking about the silent killer, when we're talking about heart disease, we're actually talking about hypertension, because that is something that is truly that anything in the body, if it's a sudden situation, that's when the body collapses. But if it's something that's over time, it's able to accommodate greatly. That's why some people will come in and their blood pressure will be extremely high. And they're like, how are they functioning? Because the body is able to make little adjustments consistently. But as far as what are we doing to support, we have multiple situations when it comes to cardiovascular, specifically the cardiovascular division, that we have a hypertension clinic to help our primary care physicians help with blood pressure. The long and short of it, honestly, is we just need to be able to have more hands that are touching the patient more often, so that you have more than one person to call. This is a team approach. If we rely on only one person, it's not going to be fixed or affected as well. The more people that we have, the more phone calls that you can make to different people so that we can coordinate multiple care, it's better for you, because all things can happen. There's times that if I'm in with a procedure and my patient calls, like they're calling me and Alex at the same time, you know what I mean? And it becomes and then also within my office, we have nurse practitioners and physician assistants who help us as well. And if you have multiple people and it's being sent to this one group where there's multiple people who can answer, the long and short of it is to get it so that you guys are answered in a timely manner. And the only way to do that is to have more people comfortable with you. Yes, we are physicians and we can all treat in general, but each person is unique. So the more that you have that know your story, know your struggles, know what you've been through, and we're able to make adjustments like that. You're not just throwing darts at random medications for random people, but tailored to that person, the better we're going to have with long-term results. Also, from high blood pressure in general, there is a new procedure called renal artery denervation. Now, this is somebody for resistant hypertension. This is not for somebody who just comes in and we're starting one medication. But for renal artery denervation, it goes in and it causes an ablation around the renal artery where it kind of like numbs the nerves, so we can start taking medications off. So I know I've been talking about giving medications. I'm trying to throw a bone out that we are trying to take medications away. Weight loss is a very big important factor when it comes to high blood pressure. I mean, when you have less tissue to support, your heart doesn't have to work as hard. And it doesn't have to go through all these capillaries, because fat is a very vascular tissue. So it has a lot of vasculature in it. So the heart has to push all that blood through all that as well. So blood pressure goes up. Also, when we're talking about blood pressure, everybody's thinking about primary hypertension or essential hypertension. There's also secondary hypertension. So if you're having blood pressure problems and it's not being fixed, is this a thyroid problem? Is this a renal artery stenosis problem where the arteries in the kidneys are blocked, so it's causing problems, so they can't function well? Is this a a tumor called a pheochromocytoma that's releasing certain endocrine situations that is causing your blood pressure to be elevated. There's a lot of different things that could be on top of it. So it's really a multidisciplinary approach that is really what Trinity is trying to do, and basically just fostering this conversation where the primaries and the specialists and everybody in between are just constantly speaking to each other.
Yeah, and speaking to some of the stuff that Trinity's doing, and the forefront of this is our communication with our specialists. Obviously, it's easy for me and George and Ange to pick up the phone and call each other, but when you're going to your physical therapist and they're noticing that your blood pressure is elevated, they are reaching out to me and giving me a little message so I know that the blood pressure is elevated, how high it was. If it's extremely high, then we're getting in contact with the nurses to get in contact with the patient to see what's going on. Do they need to be seen right away? So on and so forth. And then when I see patients in my clinic, and I think this is pretty much across the board with Trinity for primary care, if you have an elevated blood pressure, we want to see you in 4 to 6 weeks. We have to see you in 4 to 6 weeks. We want to make sure this blood pressure is coming down. That's how important we think it is. And that's one of the standards that Trinity has been setting. So it's been very helpful in that regard. And just so people know, George was talking about resistant hypertension. That means when you're on multiple medications and we still can't get it under control. That's what we start going towards and looking, hey, something else might be going on than just plain old regular hypertension. Like he said, is it the kidneys? Do you have a tumor? So on and so forth. So, but that's what Trinity doing. Trinity is making sure that we can all communicate with each other, because the more I can communicate with the specialists who are also seeing the patient, the more data we're getting, then the better treatment you're going to receive.
I think one of the other cool things that I had that I think Al's clinic had that I thought was super awesome was your communication with pharmacy and your ability to get them in and stuff. That's amazing. I don't know if George he might be more aware than I was, but I thought this was super cool. Do you want to speak more about that kind of pharmacy connection you guys?
Yeah, so we have a clinical pharmacist on staff here. She's great, Lauren Stonerock. She helps in terms of she can help look at your blood pressure, see what medications you're on, see if there's any interactions. But also a big thing that she does as well. Hold on, I'm getting a message. Close that. Also, what she does as well is communicate and try to get things covered for insurance, because I can prescribe all the medication in the world, but if you can't afford it, it ain't going to do you any good. So that's where she comes in, and she will work with the insurance companies, and she knows what programs are available to get medications that would not otherwise be covered. And getting GLP-1s covered for weight loss is another big thing that she helps with.
Awesome. Thanks. I think that was I think we answered this question. When does a primary care provider typically refer a patient to cardiology? I think we talked about like the chest pain signs and all of that. I think the question that some people have is, when you have someone who has chest pain, are there ever moments where you will just refer to cardiology, or will you always consider maybe doing a testing before you even see us? Like, is there stuff like that goes through your mind? Or does it depend on how bad the patient is? Or
Oh yeah, it always depends. We'd like to try to we can get EKGs here in the office. So we're taking an electrical kind of picture of your heart, seeing what's going on with it. Is there any actual signs of acute things going on right then? Then we're getting your butt over to the hospital, and you're definitely going to see George or Ange. Or are we not really seeing anything, but your symptoms are sounding a little suspicious? So then we start reaching out for the stress test, which comes next. And there's lots of different forms of stress tests, between putting you on a treadmill, but people that can't walk, like we talked about with arthritis or knee replacements and so on and so forth, or back pain. Then we have chemical induced stress tests. So we can kind of stress your heart out and see how it's responding. So sometimes, and a lot of times as primary care, we order those first, and either George or Ange are obviously going to be reading it, or our other great cardiologists here. And then they kind of give me a heads up and they say, hey, this is what's going on. This is how bad it is. And if it's really severe, they'll just reach out to me directly, like via call or something, and they'll just say, "Hey, I'm going to be trying to work on getting this patient in right now." So that's kind of how that works.
The other thing I was going to ask about, and maybe I can also feel this to George, one of the things people do for screening for lung cancer is a CT coronary chest. And in the CT coronary chest, I will get a lot of referrals from primary care doctors because we see something called severe coronary artery calcification. And so I think that's one of the times that maybe sometimes you may bypass a stress test and just send them straight to me if you're seeing the right patient population. So I guess this kind of question is for George, like, when you're seeing, what does it mean when they're talking about this on CT chest? How scared should people be? Like, what should they be doing? Like, what are we doing as cardiology?
So if somebody's saying that you have calcifications in your coronaries, you now have coronary artery disease. So that's basically whether it's inside the lumen of the artery or it's on the outside, depending on it, because there's walls within the arteries itself. And then there's the actual tube where all the blood is being given. You have now deposits of calcium means that you had soft plaque that is now scarred down into calcium, which, like Angela said earlier, is what we want because that doesn't move. Okay, where soft plaque is actually the more dangerous of the plaques because that's the one that actually causes heart attacks. Because what happens in a heart attack is that it breaks open, the body goes, "What the heck is this?" and attacks it. And then actually, it's your body that's actually usually causing the main heart attack. It's not the plaque. It's the plaque comes in, and the body goes, "I've never seen this before," and it attacks it, and it causes a thrombus to form, and then you have a heart attack. Now, you should be cognizant. This is not something as necessarily that it should be something that's a panic situation. What it should be is this: how worried you should be how you feel. Very, like I tell my patients, very rarely is there an emergent situation that I come across from a patient that they're not telling me it's emergent. If somebody's coming and saying, "I cannot breathe, I cannot catch my breath, I cannot, you know what I mean?" And then you see them panicking and all that, that's an emergency. Very rarely is somebody just sitting here like this and having a heart attack. That doesn't happen. So what it becomes is it becomes less of an emergent and more of an urgent and something that we actually need to take care of, but it doesn't have to happen at this exact moment. And it may not be as flashy as putting catheters and wires into the heart to fix something, but it's putting you on just a statin or on an aspirin, so that we're treating things preventive. There's a question in the Q&A, saying, well, like, do cardiologists necessarily do preventative? Yes, we do, but that does not take us completely out of like that. The primaries cannot handle it. So from answering that question too, when to refer is it's how comfortable your primary care physician feels with handling the preventative situation, and then also like do you want to see a cardiologist? There's something that could be seen that, so just having, it's not disrespect or anything to your primary doctor, but just the fact of coming into another physician and saying, yes, I agree with this, or no, I don't, and this is why, is never a bad thing. I tell from a cardiac, like I have patients who come and say, well, I really like a second opinion. And I say, please go. Two things happen. One, I'm right. And I can go, no, 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 I'm just joking. But like the second one is you go and I learn something. And another physician brings up something that I haven't thought of or I haven't seen. And it makes me a better physician. We're all human. None of us are perfect, but when somebody is no longer willing to learn is when we come to problems in our profession. And it doesn't matter if they're 90 years old, the physician, they're willing to learn, or they're fresh out of training. It's when that person decides, I don't want to learn and I'm completely right at all points in time, is when you run into problems. So as far as when to refer to us, I'm here to help whenever the patient needs help or whatever my primary care colleagues need help. I don't care if somebody's like, well, maybe it's something beneath you. There's nothing beneath me. Like both Angela and myself were internal medicine physicians before we're cardiologists. And that's by design in our training. We need to know and need to be aware of the whole body before we can specialize in just one organ. So like that's not that's to say that yes, we're specialists in the cardiovascular realm, but we understand the primary realm as well because we had to go through that realm to get to where we are. Do you think that
Yeah.
answered it, Ange?
Yeah, I think that was perfect. I think that like I mean, long story short, like it's whenever you and your primary care does that like provider, oh my goodness, feel like it's time to kind of phone a friend. Like we are here to help whenever you guys are needed. We want you to feel safe. We want you to be safe. Our job is not even our job. Like we want you to do well. Like that's like
Yeah.
the long and short of it. We're all here to help. So
Looks like we have another question on the Q&A. He's saying not much about diet and exercise here. If you come see me, we will talk in depth about diet and exercise. It is what we do. You have to learn about it. It's very, very important. It is the number one thing that can make changes in your life. Okay? 150 minutes of moderate intensity exercise per week, divided up however you want. Super, super important. Changing up your diet. We've learned a lot of new things. Carbohydrates are not as good as we once thought they were. It's super important to come off of those. Make sure you're having plenty of lean protein, plenty of good vegetables. These are all very, very important things. And I like to talk to my patients in depth about them. And sometimes we just go through and say, hey, what are you eating on a day-to-day basis? Where are things that we can improve? And go on from there. Not to mention, not just diet and exercise, but also sleep. Very, very important.
I think, yeah, I think diet and exercise. If you want us to talk a little bit more, I'm more than happy to. When we talk about diet and exercise, I think the problem is that we have run across so many different changes in medical field when it comes to diet. It will make your head spin. And I do think that there are sometimes even doctors, when we're trying to look at the information, we're like, okay, we have so many new things going at us. What do we do? What are the things? The studies that have shown for heart disease are specifically mentioning something we call the Mediterranean diet, which is like lean fish, lean chicken, olive oil, lentils. But I think sometimes I'm a person and I like to think that I'm a realist. And I think George and Al are also the same way. Like sometimes for certain people, that diet just is one, really confusing, and two, it's not feasible. Like maybe you don't like chicken and like maybe and it's not that beef is 100% like off the table. It's just you have to be careful and know how much to eat and when to eat and how do you fill your plate and how to make sure you're getting all the nutrients you need. I think most of the things that I love to tell my patients is if you can stop pop and if you can stop and start with like getting rid of all the processed sweets and like making sure that your plate is less simple carbs and more the complex like sweet potatoes, like having your squashes, like green leafy vegetables, like that kind of stuff. I think you'll be surprised at how many changes are. And even if the weight does not drop off and you feel and do more functional things, you have still accomplished something.
Yeah.
I like to go ahead, Al. Go ahead.
No. I was just going to say, I completely agree with that. What your goal is, I tell patients is we focusing on health. Are you feeling better when you're changing these dietary things? Don't focus on your weight, because if you focus too much on your weight, you're going to become anxious about it, and then that's a whole different problem. And your anxiety is going to shoot up, and your cortisol is going to shoot up, and that's going to cause a mess of problems in itself. So we need to focus on health, how you're feeling.
I like to tell my patients too, like when it comes to diet, the easiest way to think about it is when you go into the supermarket, anything on the outside you can eat, anything on the inside you can't. So, like if you ever notice the way the supermarket is set up is all the healthy, the meats, the vegetables, and everything are on the perimeter of it that you have to walk through all the aisles to get to. This is by design on purpose. And then also what I'd like to tell patients as well is, like they say, well, what about fruits? Fruits are good. But also if it's sweet, that means, it takes one step in your body to convert fructose into glucose, which is table sugar. Okay. And that one step is excellent. And that's why your body likes it because it tastes good. And the way that you deal with fruits is that's your dessert. You don't have cakes. You don't have anything like that. Your fruits are your dessert, and your main meal are the vegetables and meats. And the more that humans touched it and processed it, the worse it is for your body. And whether it's cardiovascular health, kidney health, brain health, anything we've touched. But we also have to be very cognizant of the fact that that's also the most expensive of the foods. It's problematic for our patients, especially our patients who are constrained, especially in this time. Everyone has a constraint socioeconomically when it comes to the food. So it's something to keep keep in mind.
Yeah, definitely.
And I think the other part is like, we're not saying that weight is not important. Let me caveat, but we are saying that if you gave me a person who is 200 pounds and can run 4 miles, or a person who is 200 pounds and who does nothing, the person who is 200 pounds and can run 4 miles and not have a problem is doing way better in their health than the person who's doing 200 pounds and just sitting at home.
Agreed completely. Guys,
anyone else have a question on there, Al? Because I can't see the
yeah, it says this is probably better for you guys. It says, why aren't heart tests available to have done more frequent instead of waiting until last minute, like ECGs, echocardiograms, stress tests, coronary CT, angiographs, and cardiac MRIs?
So I will say the most ubiquitous that we have is EKGs. And first of all, testing should only be done if there's a reason to have a test. Like we do have screenings, we have all those capabilities, but the idea that we just order something and like shotgun it can make a lot more problems for a patient than not, because not all tests are not 100%. Let's just start with that at first. So when we do that and we start going down this road, it can cause issues from that standpoint. Now, I kind of understand where this where we're going to in general, but a lot of it also has to do with the world we live in. We have private insurances, we have public insurance, we have a lot of stuff where it's not just we order it and it gets done. It's not even, there's a lot of times where physicians will say, hey, I believe that this is something that's beneficial, and insurances will just say no. And we're stuck in this situation. We try to do what we can to get the care that we believe is necessary for the patients, but it's not as easy, cut and dry. And now I do when I'm reading this Q&A, like, there's a whole spectrum of tests. An EKG and a cardiac MRI are completely different. An EKG is something that is very, usually capable of done in any office, a primary care office or a cardiology office. Whereas a cardiac MRI is something that's much more intensive, something that takes 90 minutes usually for a patient to get done. And there's a lot of other situations too, and it's constrained because it's not just a cardiac MRI machine. It's an MRI that's being used for all specialties and all things in medicine. So we want to make sure that we just don't inundate our diagnostic programs with people who really are not going to get much benefit out of it as well. I know that this is where the art of medicine and the science of medicine have to meet.
Yeah.
I think part of it too, kind of talking about diagnostic testing, because I think George and I reread, and I read cardiac MRIs, but I want a couple things to be said. One, the first thing George said about talking about testing, about screening, we are taught that when you go through medical school and you have a test, you order a test because you're hoping to confirm a diagnosis. You're not ordering a test because you think it's going to give you the diagnosis. So, and the reason why this is important when we come to stress tests and things like that is that if you're not having a problem, sometimes with people who have blockages and maybe your heart has recreated the connections, we won't put a stent or do anything. We may just do medical therapy and do exercise and stuff. And so sometimes when we're doing these testing, I never order a test that I expect is going to give me a diagnosis. I order a test because I'm working through differentials or like things that could be possible, and I'm trying to rule something out. That's the whole reason why I order a test and we go through it. The other thing about testing, and I don't think we talk about this enough, but testing is not benign. So some of the testing that we do, if you are not prepared for it or we're doing it too often, can have, and if we do it too often, can have negative benefits. So from my perspective, when it's coming through and we're like thinking about testing and we're talking about whether or not someone should have something done, I really have to weigh to myself pros and cons and be like, if this is going to change how I treat the patient, then I'm going to order a test. If this is not going to change what I do for you, I'm not really sure what the purpose would be. If you're doing well and I get a test, it's kind of equivocal, and you're telling me I can do and run and do things. There's no real reason to go further into testing sometimes. I know that sometimes I think that there's a lot of discussion about moving medicine in that direction, but right now is the way that I practice medicine. I think my brothers do as well, is that a test does not diagnose you. I diagnose you. I sit through there. I listen to your history, and we as an group create an educated plan for you as to what's going to be good testing for you and what's feasible. So I think that's also part of it. It's not. I wish it was cut and dry and easy that we could just scan and do it for that. Right now, we're not like Spock and all these cool tech things. We're trying, but not quite yet. You are muted, sir.
I was just saying that I'm agreeing with you completely.
Is there any other questions in the chat that we should look at, or should I?
Well, let me see.
I think one of the other ones, while I got, I guess this is actually kind of a good question. I don't know. I know I'll comb in the chat and see.
Oh, sorry. We just have a question. How do you distinguish between an athletic heart for someone who runs 500 miles a year versus a disease process?
Honestly, what I tell these patients, it's very simple. If you've been running if you run 20 miles a day, like, you know what I mean? And then suddenly now you're only running 15 for no reason, and it's been consistent, not like, hey, I twisted my ankle and it's been a problem, but like you've noticed over the next like 4 or 5 months that there's a problem, that's when I will start to dig. Like, it's a relative change for you, you know, is basically, because automatically if, somebody comes in and they say, yeah, I run 15 miles a day, I'm going to be like, oh, I mean, I wish I ran that in a year. But like, like it's all relative to the patient. So, but in the next sentence, they say, hey, I usually run 20. You're like, oh my God, well, something's changed. Maybe we have to dig a little bit further.
And I think with this question, I don't know who asked this question. This person may or may not have some type of health background, but I think the old school way of managing left ventricular hypertrophy or thickening of the heart muscle in regards to being an athlete was having the person basically do a whole bunch of nothing and then repeating the study and see if the LV thickness decreased. And I think as of right now, that's how I still understand it. But usually there's a specific measurement we're looking for that will tell us if, hey, this is pathologic even for an athletic heart. And then we go from there.
Yeah. So I kind of looked at this slide right here. What are the different roles? My role as a primary care is to do as much as I can for you to the best of my ability to make sure that you're getting treatment. And then once my knowledge runs out, that is when I'm sending you over to George or Angela. Okay, that's how that's supposed to work. They have extra training. They've been doing this. They focus on this stuff. I have a general knowledge of that. They have the specific knowledge. So when we start the workup, that's what I'm doing. And sometimes it ends with me because I'm like, oh, we have a little bit of something going on. We'll just get you on the correct lifestyle changes, medications, so on and so forth, see if we have an improvement. And if we're not, or if it's more severe, then boom, you're getting over to cardiology. You just bought yourself an echo, my friend.
Yeah, and I think the other part that they misunderstand, and I think George gets this stuff too, because we have some times where they'd be like, well, I don't know why my primary didn't know or couldn't do this. I think that what you have to understand is that the primary doctors, the way that I see a primary doctor is a general who's over a whole bunch of like different colonels. And each colonel has their own battalion and their own specialties and stuff that they do. And so they're trying to kind of guide and help go where things do. My job is literally my unit. My job, yes, I care about what's going on everywhere else, but my job is to make sure whatever I'm doing is up to shape. And so I report basically back and be like, hey, the heart's doing this. This is how we communicate. Or, hey, I'm worried about this. Or, hey, I'm not actually worried about this. Do whatever you need to do regarding A, B, and C. So that's kind of how I look at it. I don't know, George.
So one thing that I think that is likely a confusion when it comes to cardiovascular health, and particularly chest pain in general, is chest pain from the heart is actually usually one of the least common reasons why you're having chest pain. Oh, the most common cause of chest pain is musculoskeletal. The second most common cause is musculoskeletal. The third most common cause is musculoskeletal. Then you have fourth, which is GERD. And then we're at the bottom from the heart. The difference is, though, with the heart that if you miss it, someone can have absolutely devastating consequences and potentially pass away. So that's why we come to the forefront, but we're not the most common. So also, Angela said it greatly. The primary care physician is the main person, period. I always tell my patients, and like, I don't know if anyone on here has ever seen me in the hospital. I say I am sexy ghost recon. I come in for a surgical strike, come to do something, and then we come away because the primary care physician is the end all be all. And a lot of times in the hospital, you can say that. We'll say, well, your heart is good. And we'll walk out and everyone will say, well, the cardiologist said, but I'm just the heart. They're everything else. They're looking at the entire body. Yes, we try to look at it too, but like that's why we specialize in different things, because we specialize in the heart. Check off that if this is a problem, and then let the primary care physician, who is looking at everything as a picture 24/7, make further changes.
Thank you, guys.
And I think, I don't know where our moderators are.
I am right here. I was just going to say we are over a little bit, but if you guys would like to answer this last question, or we would be happy to put additional resources in the follow-up email. I know that you guys have already given us so much of your time today, and we have had a few attendees just start to drop off with the lunch hour wrapping up. So it's up to you if you'd like to just wrap this last one up, or if we want to provide those resources in our follow-up email.
It's up to you guys. I don't know how your
Well,
clinic is, Al.
Yeah, I kind of have a patient waiting. I would love to answer this question, but maybe we can have
The follow-up emails and stuff.
Yeah.
And I think I speak for all of us. If there's something more that they wanted us to talk about in this type of format, and maybe have a little bit more Q&A, I think all of us would be willing to do something like that.
Of course.
Yes, this was wonderful. And we would love to have you guys back another time and we can dive a little bit deeper into some of these topics. But at this point, we will wrap up and we would like to express our deepest thanks for you guys joining us this afternoon. That was a great presentation, Q&A. You guys covered a lot of information and we really appreciate it. Covered a lot of great questions in the Q&A as well. As a reminder to our attendees, this has been recorded and you will receive a link to the recording. And as mentioned, we will provide some additional resources in that follow-up email, many of which were covered today, but there will be additional details. So thank you so much, everybody.
Thank you guys so much. Take care.
Yep. Thanks, everyone.